Hello, and welcome back to the Aced It podcast. This is season 9, of course, where we turn science into sense. In this season, we provide 10 timely episodes with the hopes of helping listeners understand what we can learn from current research on harm reduction. And let me just say, there is so much here to learn. So, I'm glad you're with us. I'm Danielle Rudes, your host, and this is Aced It. Hospitals often represent first-line treatment for individuals struggling with substance use disorders. In fact, according to the U.S. Centers for Disease Control and Prevention, the CDC, approximately 26% of hospital and emergency department encounters between 2020 and 2023 involved drug use-related issues, with just under 3% involving opioid-related visits alone. Some studies found that 8.7 million individuals are admitted to U.S. hospitals in any given year for drug-related problems, and a staggering 17 million emergency room visits in a year are drug-related. This means that healthcare providers will likely see at least a handful of individuals with drug use-related problems every day. This, of course, makes sense. Drug use can and often does come with an associated range of physical and mental health issues, ranging from liver disease and infections to schizophrenia and psychosis. Doctors, however, are generally only tasked with addressing repercussions of drug use, attending to infections, for example, and we don't know much about harm reduction efforts within hospitals and emergency departments. In this episode, we discuss experiences of individuals who use drugs and their experiences with the medical system, and what the research suggests we can do to improve the limited existing harm reduction efforts in hospitals or in the medical system. To begin, we look at a study published by Simon, Snow, and Wakeman in 2020 that aims to understand why patients with substance use disorders leave hospitals against medical advice. Leaving a hospital against medical advice, or AMA, is linked to negative health outcomes, readmission to a hospital, and even death. So, not something that is advisable. Simon and colleagues are specifically interested in why individuals who have substance use disorders leave AMA. To this end, they interviewed 16 people at Massachusetts General Hospital who have a substance or opioid use disorder and who have previously left the hospital AMA. The researchers worked with the hospital to identify current patients who have a substance use disorder listed in the hospital's record system. If the patient did not speak English, was in the intensive care unit, or in the psychiatric unit, they were not able to participate because they may not be in the right state of mind to answer the researchers' questions. To incentivize participation in the study, the researchers gave patients $20 gift cards. The 16 people who ended up being included in this study were evenly split between men and women, and most were non-Hispanic white in their 30s. 7 individuals struggled primarily with opioids, 3 struggled with alcohol, and 6 presented issues surrounding both opioid use and alcohol use. Of the 16 people included in the study, 10 were categorized as homeless. For 7 people, the reasons for initial admission to the hospital was substance use related, including withdrawal symptoms, and 5 were admitted due to an infectious disease. In other words, some people in the study were admitted to the hospital directly because of their substance use disorder, while others were admitted for situations that were otherwise detrimental to their health. The interviews conducted by Simon and colleagues were semi-structured, which means interviews had a general guide, essentially open-ended questions to ask the patients, but the patients were able to broadly talk about their experiences within the hospital. 4 themes emerged from these interviews. First, many people described that their interactions with hospital staff were overall pretty negative, that they were judged by the healthcare providers for their substance use disorders, and that sometimes they did not receive the care they believed they should have received. The second theme that came across multiple patients was a lack of pain management provided by doctors. In other words, many people felt that healthcare providers not only judged them for their substance use disorders, but also let this judgment affect what type, if any, pain management was offered. Patients believed, for example, sometimes requests as simple as ones for ibuprofen were denied because the health provider did not want to give a person with a known substance use disorder another substance. This led to some people leaving the hospital against medical advice. Third, people described issues surrounding withdrawal symptoms and poor management of these symptoms. Some said that they were left to go through withdrawal cold turkey. In some cases, people reported that they left the hospital AMA and immediately used drugs to stave off withdrawal symptoms that were not managed by healthcare providers. Finally, interviewees were dissatisfied with the inability to move about the hospital and hospital grounds. It was restricted. Some compared the hospital setting to a prison, which limits their ability to get fresh air or see their partners. If we put ourselves in the shoes of the participants of this study, it may make sense to leave the hospital, even if a doctor warns against it. Imagine suffering, for example, from an opioid addiction and getting an infection from using an unclean syringe. The infection gets bad, and you finally decide to go to an emergency room. There, you fill out the intake form and do so honestly, disclosing that you have a substance use disorder. Now the staff's attitude toward you changes. You aren't left in your room alone, and you are under constant supervision. While your infection may be cleaned up, you aren't given any medication to deal with the ensuing pain. And when you have to stay the night, you start going through withdrawal as you don't have access to your substance of choice. You can either continue to deal with the pain from your infection and the onset of withdrawal symptoms, all while experiencing judgment from the staff, or you can leave. Really, you're stuck between a rock and a hard place, and it makes sense that some people decide to leave the situation completely. If we look at these results altogether, we see that harm reduction efforts are not really present in the hospital described in the Simon and colleagues research article. People who use substances tend to feel judged by hospital staff and don't necessarily have all of their needs addressed. Because of how widespread substance use disorders are, and because hospital staff do see many individuals who have substance use disorders, remember, about 17 million people enter the ER with drug-related issues each year. There's definitely room for improvement here. One way we can begin to address this issue is by providing harm reduction education to healthcare providers. While we might expect medical professionals to be well-versed in substance use disorder, the study by Simon and colleagues suggests that this might not be the case, and that education in this area could be incredibly beneficial to both healthcare providers and patients. In fact, it could even help reduce overdose deaths, as individuals with substance use disorders may be more likely to seek care if they know they will not be judged and will receive appropriate and caring medical assistance. Pereira and colleagues published an article in 2022 entitled Meeting People Where They Are, Implementing Hospital-Based Substance Use Harm Reduction. This article examines a program that does just this. More specifically, the researchers worked with community organizations to provide hospitals with harm reduction education and supplies. Educational materials included things like flyers that discuss, quote, never use alone, overdose prevention hotline, and supplies included things like clean syringes and fentanyl test strips that hospital care providers could give to their patients who struggle with substance use disorders. The good news that comes from this study is that hospital leadership was very open to providing harm reduction education and supplies. During the course of their study, Pereira and colleagues gave harm reduction kits to 195 people. Even individuals who in the beginning were reluctant to work with the addiction care team became interested once they learned more about the program. This is certainly a step in the right direction, as it educates both healthcare providers and patients on harm reduction efforts and has great potential to reduce drug overdoses. In summary, while hospitals see millions of individuals each year who struggle with substance use disorders, most healthcare providers are not prepared to provide the level of care, or a level of care that is free of judgment. This makes the hospital environment an ideal setting for advancing harm reduction efforts. Doctors can provide patients with education and supplies that can reduce the risk of overdose, and this can all be done in a caring and judgment-free environment. Thank you for listening to the ACEDIT podcast. We love hearing from you. So if you have comments, topics to suggest, or some science you'd like us to cover in a future season, please write to me, Danielle Rudes at Sam Houston State University. My email is drudes@shsu.edu. And of course, thank you to the Justice Community Opioid Innovation Network, or JCOIN's Coordination and Translation Center, funded by the National Institute on Drug Abuse, housed at George Mason University, where this podcast originated. Thank you to our fabulous scriptwriters, Dr. Alyssa Toman from Texas State University and Sam Houston State University doctoral student Caitlin Bauer. And a huge and heartfelt thank you to Jason Luchin and the team at Slonky LLC for their spectacular production. Tune in again soon for another episode of Aced It.